Good afternoon, everyone. This is Kevin McGinnis, welcoming you to the September 2020 edition of the Community Paramedicine Insights Forum, brought to you by the National Association of State EMS Officials, National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. We are glad to be back after a brief, well, not so brief, but a COVID break, and getting focused back on community paramedicine once more as we go into the fall. February of 2011 was our very first Community Paramedicine Insights Forum. And at that time, we wanted to feature programs that were trying community paramedicine and had some experience that they could share with others. And one of the first programs to formally organize in the country in a rural setting was, at that time, Western Eagle County, Colorado. And we had Chris Montera join us and describe how they got their start and what they were up to. And we thought, darn well, about time to revisit. Actually, we've been back to Eagle County a couple of times on our shows, but it's been a while, and so we asked Kevin Creek, who was the first community paramedic in Colorado, and obviously the original paramedic, community paramedic dude at Eagle County, and one of the first rural community paramedics in the country, to join us today. Kevin built the Eagle County program by writing protocols, policies, and procedures, and educated nurses and doctors on the benefits of using CPs in non-emergent situations. He's become a very familiar speaker around the country on the subject, and we're pleased to have Kevin Creek back with us today. Obviously, their program has evolved. Western Eagle County is combined with Eastern Eagle County, is now simply Eagle County Paramedics. And so Kevin's responsibilities have spread, but he's doing the same thing that he established so well and so strongly in that portion of Colorado. He's going to talk to us about some new programming that is underway and of great interest to us in general, since mental health issues have become more of a request for CP programming. We're going to hear a bit more about that. And so without further ado, Kevin Creek, welcome. Please take it away.
Thank you very much, Kevin. So the first thing I'm going to ask Kevin and Gary, I didn't even think about this. It's a little warm in my office, and I've got my window open. Can you guys hear the trucks going by? Is that annoying to you guys, or is it not even coming through?
Can't hear a thing.
Okay, good. Well, if it ever becomes a problem, just let me know. So thank you guys very much for the invite to do this, and welcome all of you who are also joining. It is absolutely my privilege to be able to share with you where Eagle County has gone since the inception. Seems like we've been doing this forever. Although I know it's only been 11 years, and in the history of EMS, that's kind of a drop in the bucket. So I just wanted to give before we get into what I'm here to talk about, just give a brief introduction of where we came from. So back in 2009, Chris Montera, who was the CEO for us, has actually just left to move on to Florida to be with a grandson and his son and his wife. Chris came to me and said, "Have you ever heard of community paramedicine?" And in 2009, I had not heard that term and said no. And he said, "Well, it's this concept." And he'd been kind of thinking about this stuff for years anyway. He got in touch with Gary Wingrove. If I understand the whole timeline right, those two kind of conspired to fix a bunch of things in the EMS world and innovate and do those types of things. And so we began this long process of starting our program. Actually, I want to jump back. It was 2008, not 2009. So in 2009, we started to kind of how are we going to do this? And there wasn't really anything out there at that point. You couldn't look up on internet and find community paramedic programs that existed and things like that. So like, I think it was Gary, and you can correct me if I'm wrong, you told Chris to, Chris said, where's the handbook? And Gary said, well, why don't you guys write one? So we set off on the task. We hired a master's of public health and coordinated with a lot of different people and created the community paramedic handbook. At the time in the state of Colorado, they didn't know what, community paramedic was either. So we reached out to the state and they said, we told them, this is kind of what we want to do. We want doctors to send us out to patients' home and we want to help them and do these things. And they're like, okay, that's fine, whatever. And so we started our program and we were about 5-6 months in, and we learned, the state called us and said, we're getting 3 to 4 calls a week wanting to know what this community paramedic thing is that you're doing. Can you tell us what you're doing? So we described it to them again, and they said, that kind of sounds like home health. We think you ought to have a home health license, so we need you to put your program on hold. So we did. We had to, for 6 months, put our program on hold. All the progress that we had made kind of fell off the shelf, and we attempted to apply for a home health license, a conditional home health license. Well, as you can imagine, we failed horribly the first time we sent in our application. 95% of it was not applicable. The other 5%, we really weren't sure what they were talking about. So we ended up hiring a woman who used to work for the state of Colorado in their home health agency, and she then helped us write the application. So funnily enough, when the state came out to review our application and either grant us or not, they sent someone who had been on the job for 2 weeks. And she walked in and we handed her 13 4-inch binders full of things that we had created in the handbook and protocols and policies, and she was just extremely overwhelmed. But we also had the lady there with us who kind of helped guide her, and we were granted our temporary home health license. We had to operate under that for quite a few years, which in hindsight was not the worst thing in the world. It all worked until we were finally able to, through the help of Senator Garcia here in Colorado, who actually is an ex-paramedic. I think he's actually still a licensed paramedic, not practicing, help us get legislation passed through the state of Colorado. That then took a couple of years for that to get all the policies and procedures written at that. And last year, we finally started having endorsed community paramedics in the state of Colorado. In the state of Colorado, you have to have gone through an accredited community paramedic program. So either through an accredited training center or a university in order to apply for credentialing. And then you also have to have passed the IVSC test endorsing you. And once you turn those 2 things in, then you are legally allowed to work as a community paramedic in our state. Just a brief, and I won't spend a lot of time on this, but and there was one other thing. They mentioned that you guys can ask questions, and I may not be staring at the questions or the chat box the whole time. So, Gary, Kevin, if something comes in, just interrupt me, because I definitely don't want to skip over anybody's questions if they have something. And we'll obviously take some time at the end to answer as well. So when we first started our program, we had a pretty good focus on what we wanted to do. We had done a community health assessment through our public health, and we knew, this was pre-Obamacare days, we knew as a rural community, and I'll kind of show you what Eagle County looks like during my presentation, but as a rural community, we knew that we had a little bit access to care, some access to care issues in a few areas. Number one, we knew we had a lot of or underinsured individuals in our state. Or in our county, as well as our state, actually. And we also knew that Colorado is a very healthy state in general when you look at kind of national statistics. And then when you break that down into mountain towns, that statistic gets even higher. We're a fairly, yes, I'm still on the title slide. Sorry about that. So when you break it down into the mountain communities, we're even more healthy, per capita. Everybody here is so many people are outdoorsmen. They run, they ski, they hike, they do all sorts of things. But at the same time, we had a lot of elderly in our population that had access to care issues because we don't have, a lot of taxi cabs or things like that, or services, at least at the time, that could really get people to the doctor's office. So going into this, what we wanted to do was we wanted to focus on keeping people out of the hospital that, we could prevent things, and then also keeping them out of the doctor's office if it was going to be a burden for them to get there. So those were our initial goals. And so we sat down with all of our community partners. Montera used to say, you can never go on a diet when you're starting a community paramedic program because you're constantly taking people to lunch and dinner. And we did that with county commissioners, doctors, lawyers, school districts, everybody we could think of, we talked to them about this. And that's kind of how our program got off the ground. With those initial goals of, just keeping those two people or those two classes of people in where we wanted them to go. The way I like to say is that I get to speak a lot, not only around the country, but also to groups here in the Valley. And I call it the aha moment. And I might have a slide on this later, but the aha moment is when you're talking to people about what you're doing, they're like, aha, you can help us with this. And so our program has grown exponentially in a lot of different ways. But today I really want to focus on one and throw in another piece of it that is very closely related to that. So with that, I'll kind of start some slides. Again, if you guys have any questions, let us know or let me know, and I would be more than happy to ask them, and then we can talk at the end. I do like participation. If you guys have anything, I know this is a difficult format for that to happen. I can't see into your eyes and see if you're pondering something. So just raise your hand, type something in the chat, and we'll be sure to get to it quickly. So kind of the introduction that Kevin touched on. My name is Kevin Creek. I have been in EMS for 24 years. I began with an organization called MAST in Kansas City. It was the entire city EMS system for the city of Kansas City. I can't remember what it stands for now. But I've been a paramedic for 22 years. The first part of that, obviously, in Kansas City. And then we moved to Colorado in 2004. So when I first moved to Colorado, I moved to a little community known as Buena Vista, if anybody's ever heard of that, up in the mountains, small little mountain town. And I worked with them for a year. And ironically, Chris Montera was living in Eagle County at the time and working for the state of Colorado and had gotten hired to be the director of Western Eagle County Ambulance in Eagle, Colorado. And we had gotten to know each other, and he asked me if I would be willing to come over and apply, and so I did, and I started as a paramedic there in about 2006-ish, and I was hired on full-time January of 2007 as a paramedic. And as I mentioned, about 2008 is when he came, to me and asked me about the community paramedic thing. I received my community paramedic certification through our local university here, through the curriculum that we actually helped write. And then I became an IBSC certified community paramedic in 2015. I was part of the original testers, and I also helped write the test. And a funny thing about that, I always love to tell this story, is that I remember writing the test and writing a question, and then when I went in to take the test, I could not remember the answer to my own question. And to this day, I don't know if I got it right. But for those of you who have taken the IBSC test, it's a challenging test. And so we're constantly looking at ways to help folks improve their test-taking ability through that. And I think one of the reasons it's a very challenging test is that if you go to Maine or Texas or Colorado or Oregon or wherever and take the National Registry test, it's the same test, and it's written by people in the paramedic industry, and it's a standardized test. For community paramedicine, as we started developing that test, there were people from lots and lots and lots of different backgrounds in that test writing group, including public health, nurses, doctors, and things like that. So there was, there's such a big conglomeration of people in that you're going to have a test that hits on so many different areas, which the IBSC, I know, wants people to be well-rounded community paramedics. And then as you go into your system and your system needs assessments, or your community needs assessments, then you know what areas you're going to be focusing on. I know Kevin had mentioned, and it's in my bio, that I got to teach doctors and nurses about what community paramedics can do. One of the things that we actually had to do first is I had to teach doctors and nurses what paramedics were. A lot of them that we talked to actually had no clue, especially the primary care docs, what paramedics did. They thought someone got hurt, you picked them up and you drove them to the hospital, and that was it. They didn't know about all the care that paramedics were able to do. So there was a lot of education on our physician and nursing partners to let them know all the skills that regular paramedics could do, let alone the extra that the community paramedics have been given. So if you take a look at the map here, this is where Eagle County is located. About 54,000, 55,000 typically. I know with coronavirus, we've lost some of that. Some people have had to move to the city where there's possibly more opportunities for work, with a lot of construction projects being shut down here. But it's typically been averaging around 55,000 for the past 5 years. We're about 1,600 square miles. And when people think of Eagle County, who haven't been there, and they look it up on the internet, they see Vail and Beaver Creek. So that is the reputation that Eagle County has. Lots of second and third homes. It's a resort town. It's very wealthy. You'll see it in movies. It's kind of like Aspen, and everyone here is wealthy and drives Mercedes-Benz, and it's their third home. But that's actually very far from the truth. So Kevin, would it be okay if let me see here. I'm having a hard time reading the slides because they're so small, but, now I can see it. Okay. No, we're good. So when we look at the cost of living index in Eagle County, it is extremely high. If you look at the top line, to the right is the national, and that's just based on an average score of 100. So people can be below the 100, people can be above the 100. Colorado in general, as opposed to national, is 10 points higher than that. And then if you break that down into Eagle County, we're 34 points above the national average. Everybody wants to live in the mountains in a resort town, and because of that, cost of living is much higher. The average home cost here, pre-COVID, if you wanted to buy a small house, if you look down about 3/4 of the way down and look at the housing index, we're 204 off of that 100. So a typical house that I would have been back in Kansas City would have cost $120,000 was actually about $550,000 to $700,000 here in Eagle County. And a lot of the jobs aren't really necessarily paying enough for people to do that. So in our area, we have a lot of people living in 2-bedroom apartments with 7 people, renting a room. My wife, she is my second wife, this beautiful lady here, when we met, she was living in Eagle County. She rented a single bedroom in a 2-bedroom apartment with 3 other ladies, and it was $1,500 a month to live in a single bedroom. So it's very difficult to live inside of Eagle County. Eagle County has, we're a pretty progressive system nationwide. We obviously have our 911 response, 90% dual medic, about 10% one medic and one EMT. We have the community paramedic program. We have critical care. We have our tactical paramedics who are actually went through law enforcement classes, and they carry weapons as well. on all their calls. We have search and rescue. We have community outreach. And I can already see that I need to update this slide because we have the behavioral health navigators, which I will talk about later. So as far as your typical 911 system, we have a lot of different things going on. One of the great things about Eagle County, so many districts I know of, you've got the one guy at the top, and then you might have one person with them, and then everybody else is working on an ambulance. And even some places, the person at the top is even working on an ambulance. We're very blessed here in the fact that we have a CFO, a COO, an HR specialist, an outreach manager, which is me, a training specialist. We have an IT manager. We have a 4-person billing department. So, we have a lot going on here. We have a full-time PIO who is trained in that. Typically PIOs are someone on the ambulance who wants to, I can go do that and I'll talk to the press. But we actually were able to pay someone to do that. So we're very blessed here, and we all know it too. So just kind of taking a look at basic call volume after the last 3 years to give you an idea. 2020, I'm not even going to tell you where we're at because with COVID, everything's completely skewed. We do know, though, that our 911 transports are down about 20% throughout 2020. However, our community paramedic calls skyrocketed in 2020. And we can kind of talk about that afterwards if anybody has any questions. But back in 2017, 18, and 19, call volume stayed roughly the same, with a hair jump in 2019. Just between 2017 and 2019, though, you can see that our community paramedic calls jumped up quite a bit. That was through some initiatives that we did, some different programs, our PR, and then really doctors just finally learning, what all community paramedics can help them with. We do know, so in Colorado, I should back up, in the state of Colorado, a community paramedic, if they're going to go out and visit the home of a patient, they have to be ordered by a physician. And all of the physicians I talk to say, oh my gosh, when I see them, I had these people and I just completely forgot to refer. I didn't even think about it. So it's a new workflow for them to think they have this help. And it takes time and it takes partners. So total call volume obviously went up because we did a lot more interfacility transfers, and we did a lot more CP calls. So the reason we're here, now that I've given the background of Eagle County and what we did, is our community paramedic division. And this is growing, and I'm going to kind of talk about that in a little bit with a couple of different initiatives. But as I said earlier, we started in 2019. The initial goals were to reduce hospital readmissions, connect those resources, and provide care in a more appropriate setting, meaning we wanted to be able to help the doctors get some of these patients some care in the home so they wouldn't have to somehow get to the doctor's office. The one FQHC that we had that was seeing non-insured patients at the time was kind of like what your dad used to say, I walked up to school uphill both ways. It was like 0.8 of a mile up a huge hill from where the bus stop dropped them off by the highway. So if you can imagine needing to go to the doctor and having to walk 0.8 of a mile up a hill in Colorado where it snows a lot was very difficult for a lot of people. The one taxi cab company we have, it can be up to $100 just to drive about 20 miles to get to your doctor's appointment. So that wasn't really an option for them anyway. So what do the community paramedics do? Ambulatory detox, I will cover in this, but we do a lot of the same things that I think a lot of community paramedics do and focus on. We are not a program that started with one goal, such as to reduce CHF, readmissions. That's never been our goal. We wanted to reach as many patients as we could, and because we're not hospital-based, we're able to do that. We're able to focus on the things that we feel are necessary. So we do a lot of INR checks in the home, a lot of phlebotomy, especially for those patients who make it's more difficult to get in. And because of COVID, those numbers have jumped exponentially as well. Physicians realize now that getting patients to come into the office is a lot more dangerous than just having us go out and do it, in the patient's home setting. HMPs, hospital follow-ups. The newborn follow-up is a program that I have been pretty passionate about for a long time. I think it's very important for someone to be there in the home a lot of times for these patients. So the baby gets discharged, and typically they're going to see their primary care within 24 to 48 hours, and then they're going to come back in another 10 to 14 days. So we like to get out there about that 7-day, 8-day post-birth. They've been home for about 4 days after their first doctor's appointment, and we just like to kind of check on them. We found quite a few babies that weren't gaining weight, and we're able to really assist in that and get them some referrals and help them with some feeding. We can refer them back to the lactation specialist and things like that. We do a lot of social evaluations with the mental health aspect of what we do. Nutrition, diabetic, medication, a lot of things that a lot of people do. Home safety is a pretty big thing for us, although we don't have a home safety. When I was speaking with Kevin about this earlier, McGinnis, we don't have a targeted where we're collecting data and things like that on our home safety. It's just something that we do for all of our patients, specifically our elderly patients, or if there's a patient that we feel there may be some sort of ambulation problem or hazards in the home or something like that. Our wound checks, dressing changes, we do quite a bit as well. We like to tell people that we are not wound care specialists. We're not there to debride the wound, but we do go in, we measure a lot, we clean, we take pictures, send those to the docs, and it really helps a lot of our wound care patients. Ear exams, 99.9% of the time, that's obviously on a child. For example, kid comes into the into their primary care, and they have a possible ear infection, and then we might be sent out 4 or 5 days later to do a recheck just to make sure that's clearing up. Again, some more asthma medications and things like that, weight checks. We do specimen collections, so we have urine and fecal as well as sputum. We're doing obviously a lot with the COVID tests, but now the physicians are wanting us to go out and do rapid streps and other types of specimens like that. And then basically what's great about the state of Colorado is that we, through our community paramedic legislation, a community paramedic can, within reason of course, do anything that the medical director says we can do. So if you compare that to a 911 paramedic where they have their list of things and it comes from the state, and these are the things that you can do. And if you want to do something different, then you have to apply for a waiver in the state of Colorado. It's got to go before the state board. And then you've got to send in paperwork all the time saying, yes, we're doing this, but we're doing it like this and this. We don't have to do that with community paramedicine. So we do suture removal and a lot of things, injections of atypical antipsychotics for patients who have been court-ordered to take those medications. So it really frees us up to move in a lot of different directions. Any questions just through the chat box so far as to kind of the basic things that we do before we get into the topic that we're here for? And I'll just give it maybe 5-6 seconds, and if I see something jump in, I'll pop and stop where I'm going. Okay, well, not seeing anything, I'm going to jump ahead. So we're always looking for gaps to fill here in Eagle County. And we know and have known for a long time that mental health is a huge gap in here. We're about 2 hours away from the nearest city. And so when you think about that in a small rural community, you don't have a lot of mental health support. We don't have any inpatient. We don't have any respite beds. These are all things that we're working on, and they will be here soon, hopefully by 2022. But those are massive projects. And so we had a big, big problem here. And we also had very little mental health as far as providers go. We had about three or four groups that did provide that, but 2 of them were private pay only. One of them only accepted one type of medication, and the other one, which is a state run, was possibly sometimes up to 3 even as long as 8 weeks to be able to get in and see someone. And so we knew there was a problem with mental health. And so we were always asking ourselves, what can we do? How can we help? How can we contribute just to answers for this problem? Obviously, there are many many reasons for high rates of mental health in an area. But when you talk about, you take away the physiological or the biological effects that would possibly have someone to have a mental health issue, when you look at living in Eagle County, you can see just from this list that if you're a person who has moved to this county and, there's no way I can buy a home, I really can't even rent a room by myself, I'm going to have to get lots of roommates. Most of the jobs, you would not pay enough to even do that, so a lot of people have 2 jobs. And then you have the seasonal work. So we get people coming in here, they want to be ski patrol. And then, so the season ends, and they're like, well, what am I going to do until next ski season? Some of them would leave, but a lot would stay and just try and find odd jobs. We have a very high rate of alcoholism in Eagle County as compared to the rest of the state. I will blame that. This is all anecdotal, of course, but I have a lot of friends who work in the industries that say they agree with this analysis, that when you look at ski patrol and river rafting and things like that, the people that work in their industries, they do their job all day, and then at night they're drinking and they're doing all these types of things, and then they just get up and start all over again. It's a hip scene, and this is what we do. We're here to ski on the mountain all day and then to party at night. And then you combine that with lack of mental health resources, and we had a major problem in Eagle County. And if you notice, the last thing on that slide is altitude. And you might be thinking, what the heck are you talking about with altitude? There's actually been some studies done that there's a very real possibility that it does raise the risk of depression and suicide. The systematic review that was published in Harvard Review of Psychology that's listed there theorizes that its low atmospheric pressure can lower blood oxygen levels and may contribute to increased thoughts of suicide. And then chronic hyperbaric hypoxia could perhaps alter how the brain processes the neurotransmitter serotonin. So and this is from across the board, and I think I actually have a slide here. If you look at the highest rates of suicide in the United States, they are clustered in intermountain states, and specifically when you break it down even further, there's a lot of it that clusters around the mountain towns. So Arizona, Colorado, Idaho, and on down that list. So it's something that we have to be very concerned about with our patients who are experiencing these types of things. Not that we're going to give them oxygen to cure their mental health. That's not what I'm getting at. But just knowing that we at altitude have a higher propensity for that is something for us to keep in mind as we kind of go through. So we knew, like I said, that we had mental health problems here in Eagle County. We just didn't know what to do. How do we fix it? We kind of felt like we were just dabbling around and, we're going to try and fix this patient or fix that patient. Yes, we know we need a bunch of big things here that are going to cost millions of dollars, but, we can't do that. So, what do we do? As with a lot of things in, our history of human beings, sometimes it takes a sentinel event to cause change. In 2017, we had a 13-year-old female who completed suicide with a handgun. To say that it rocked the community would be an understatement. I was actually able to be at the school the next morning when school got back in session. This was a school in Eagle. And when I mean Eagle, the town of Eagle, sorry. And was able to help counsel and work with a lot of the kids. And it shocked me at the beginning, and then it didn't shock me, that I had 5 or 6 girls in this girl's friend group mention to me that they felt incredibly guilty because this girl had said a couple of things on Facebook that everyone thought was just her talking and things like that. And if you talk about, if you can picture a 13-year-old girl with a handgun, you know, completing what she completed, that's a horrible thought, an absolute horrible thought. The one thing that this did was it rallied the community to say, okay, enough is enough. We have to do something, and we have to do something big. So we created a group, and this group consisted of leaders from the hospital, from our local care clinics, from the few mental health agencies that we had, police, EMS, schools, and we started to come up with a plan. We knew we needed funding, we knew we needed programs, and we knew we needed partners. Those were the three things that we knew that were going to have to get done first. The first thing we needed was funding. And when you're talking about funding massive projects like this on a countywide level, that's a lot of funding. And luckily, the head of public health, a gentleman who's the head of public health at the time, his name was Chris Lindley, and he had this brilliant idea. So in November of 2012, the state of Colorado passed a ballot measure to legalize recreational marijuana in the state of Colorado. That law was put into effect in January 14, and Chris Lindley had this idea that we could make this work for us. So we put together a ballot measure 1A. We introduced it to impose that the sale tax and excise tax of up to 5% to fund mental health within the county. This, as you can see, passed in November 2017 with a 73.7% approval. So an overwhelming majority of our community supported this. What that would give us, we would get of all of those, what it talks about earlier, so both sales tax and excise tax. So we were not only going to be taxing recreational users, we were also going to be taxing growers. 2.5% of their profits in the first year, and 0.5% each year going up into a max of 5%. And all of this money absolutely had to be used for mental health. There were very strict guidelines and reporting processes on how we would use that. And so when we did the numbers, we estimate that this is going to bring over $2 million. Of that, the first $1.5 million has to go to mental health. So earlier we talked about programs. So we now have the money. So now what are we going to do with the money? We're going to provide school-based mental health clinicians in every single school. And this is not the school counselor. This is a trained, licensed mental health professional in every building as well. School counselors, as I'm sure most of you know, are there to help kids pick a college and how are you going, what path are you going to go down. This is specifically a mental health provider, a clinician in every single school that at any time during the day, a kid can walk out of class and walk down to the mental health professional and talk, which is absolutely phenomenal. The other thing we wanted to do is we wanted to provide clinicians for the jails. We have a lot of mental health patients that come out of the jail, and so we wanted to really tackle that before they got out. And then the third is we wanted to provide crisis intervention and stabilization programs, and that's where my program comes in. So as I said, we wanted programs, not necessarily buildings. The buildings that we want a respite center. We want a social detox. These are things that we want, but those are the things that cost millions and millions and millions of dollars and red tape, and those things take years. So what can we do in the meantime? As I mentioned earlier, we wanted crisis response and we wanted crisis stabilization. The crisis response, we wanted much like an ambulance. We wanted that 911 response so that if something was happening, a patient wouldn't be told, yes, you can see a provider in 2 weeks. The other thing we didn't want, as I'm sure you know, we did not want all of these patients going to the hospital. It's the last place they need to be in an emergency room. And then the second thing we wanted was crisis stabilization. We wanted to be able to get these these patients into a program so that we could keep them safe in the short term. So maybe from 2 to 4 to 8 days, we knew that there was someone with a mental health experience seeing these patients until they could get into a full-time counselor or get them to a facility that they could go into if they were requesting that. So we knew those are the things that we wanted to do. So we looked at co-response. We knew there were some co-response models out there in the country, so we started looking at them. Most of them were with law enforcement and a social worker, or sometimes law enforcement and a mental health clinician, but we couldn't find anything where there was any medical evaluation that was also going to take place. And we felt that was very important for a number of factors. We wanted to be able to keep the patient safe in stabilization. We wanted follow-up. We want telepsych and medication management. So both from a medical and a psychological state. And we thought that was very important since so many times they go hand in hand. So we looked to the Aspen Hope Center. Aspen is in the county next to us, also a fairly well-off ski community, as I'm sure most of you know. And they were founded in 2010 after their own Sentinel event. In 2009, there was, late 2008, early 2009, there was a very prominent member of the community, extremely wealthy family member who completed suicide. And the wife went on a mission to improve mental health services in in Pitkin County where they're at. And so they founded the Hope Center. So the Hope Center's model was a co-response model with a mental health clinician and a law enforcement officer. And so we talked to them. What was kind of funny is that the director of the Hope Center in Aspen, her husband is also the EMS director in Aspen. And so we knew Gabe from a lot of different meetings. And so we got in contact with them, talked to Michelle, had her present her program, and we saw some things. But even there, that she admitted some downfalls. They admitted that when they were on scene, there were a lot of different things that they weren't familiar with. They didn't know how to handle. They had a client, if a client has any unknown medical issues on top of the mental health issue, what are these medications for? What are they taking? Are they taking them correctly? They didn't have access to health records for just health outcomes. And then a lot of times they dealt with this thing in EMS that we call clinical sobriety. Clinical sobriety is something that's very difficult for a mental health person to grasp their head around, because in the mental health world, it's actually illegal to put an M1 or to treat somebody, or to deem them safe if they are not clinically sober. So they don't have that clinical sobriety. They're like, are you sober or you're not sober? And if they're not sober, then you just got to go to the hospital. And we knew that was a barrier that we could help fix. So what we did is we created a partnership with them, but what we did is we expanded their operation and brought them over to Eagle County. So they created the Hope Center Eagle River Valley branch, and we partnered with them for our mental health program. And what does that look like? So they opened in September of 2018, and so we have a co-response model here with a community paramedic and a licensed mental health clinician, and that started in 2018. The other thing that they did is they placed a licensed clinician in every school, and in January 2019, they were able to offer the same thing to the jails. So we got the funding, we got the partners, and we got the program set up. These are goals that we wanted to do. In fact, one of my community paramedics is actually on a crisis call as we speak. I saw the call go out about 15 minutes before I joined in, and I just looked, they're still on it. So anytime in Eagle County, when someone calls 911, we get this teamwork. And I hope you guys can see the slide because it's one of my favorite slides. But we have a dual approach to address mental health in Eagle County, which I think is a really good way to do it. So the community paramedic. So we've got three scenarios that we're going to talk about: a 911 scenario, a law enforcement initiated contact, and then a direct call to the Hope Center. Okay, so a 911 response. We're not silly. We know that mental health calls can be dangerous. So in the 911 response, we make sure that if it is not simply a mental health issue, so mother calls in and said, my son has bipolar and he's screaming and punching holes in the wall. We know that a lot of those can still be medical. So a lot of times you're still going to get we're going to get law enforcement on any mental health call here in Eagle County. That's just a given for the safety of everyone involved. More than likely, you're going to get an ambulance if there's any report of there could be any possible medical issue, and then sometimes fire, although we are way backing off of fire where we're at since COVID started, especially since we know that, the fewer the people in the home, the better. But I have always pushed that if you have a mental health patient and you send in the cavalry, that is going to do more harm than good in a lot of situations. Think about being that mental health patient who's struggling and all of a sudden 15 people come into your home and then more keep arriving. It just causes more problems. So law enforcement is a must just to make sure things are good. And then that secondary response is the community paramedic and the Hope Center clinician. Now, our goal is always to release law enforcement as soon as possible. Prior to this program, law enforcement's biggest complaint with mental health patients is that they would often be on scene for up to 5, 6, 7 hours with these patients. Our goal is to get them out of there in 15 minutes if we think it's reasonable. A lot of times they're out of there in 5. If we get in, we deem the situation safe, and we've created a quick rapport with this patient, we can kick law enforcement loose. And if the ambulance wasn't there, we're not going to request them either. If a 911 call comes out as a medical and our ambulance and fire show up on a typical medical call and they quickly realize that this isn't really medical, this is a mental health issue, and they clear them medically, then they're going to call dispatch and have them tone out the crisis response team, which is that community paramedic and the Hope Center clinician. And then we'll head out there and clear the ambulance. The law enforcement model is they get called to a lot of things that ambulances don't get called to, obviously. And so if that's the case, then they have the ability as well to page the crisis response. And thirdly, a lot of times the Hope Center, because their number's out there and they've advertised, they will get a call. The thing about the Hope Center is that they are not they're not your counselor. They're going to call and go, hey, I'm struggling in my marriage and I want to come in and see someone and, start some counseling. They're not, I've been dealing with this forever. They are a crisis model. So when someone calls them and is even in suspected crisis, then two things can happen. Number one, if it's during the daytime, then that patient can drive over to the Hope Center and the community paramedic will meet them there. Or the Hope Center can then request the community paramedic and they can go out to the patient's home. So that is basically the model that we have. As far as the protocol, it's pretty self-evident from this slide, but we're going to go out and first thing we're going to do is we're going to do vital signs and a focus station P. The one thing that we have made very clear to our partners in this is that at that moment, the community paramedic is 100% in charge. So if the Hope Center shows up and they think, yeah, this is a mental health issue, but the community paramedic shows up and through either vitals or the H&P or something that they notice, they can look at them and go, nope, I'm calling in an ambulance. This patient is going to the hospital. And they've been very good with that. They're actually very thankful for that because that's something they don't have to worry about. The Hope Center in Aspen would often wonder, is there something that we're not seeing? And so we kind of take that out of them. We also have the ability to give PO Ativan for the patient that, the tragic event has happened and the patient is so upset and so hysteric that they just can't get calmed down. We can give them a little bit of PO Ativan to bring them down to where we can work with them. This does not, obviously, eliminate, or this is not for the patient that needs sedation. Those patients still get an ambulance called, and the ambulance, our crews are going to do what they're going to do. This is not for that type of patient. If it's any sort of violent patient, if it's any sort of anything like that, that's not what the PO Ativan is for. We're going to do a medication compliance, not only on any potential psych meds, but also on their normal meds. We're going to help the Hope Center with their safety planning. And then one of the great things about this is, and we actually do this quite a bit, so we will show up to a potential, maybe it's a domestic violence case, and there wasn't actually anything where anybody's going to get arrested for, but it was a huge big fight between a husband and a wife or somebody, and we really feel that, these people need to be separated for the night while we get some more answers, and so the community paramedic can actually move that patient to another location. They cannot take them to a hospital. That is still something for the ambulance to do. But our community paramedics in general can move patients to primary care physicians and things like that. So your normal community paramedic goes in and sees a patient for blood draw, and they check their blood pressure, and it's 210 over 120. That patient's going to go to the hospital. If they're having some, headaches and stuff like that. But if it's slightly elevated and they're sick and there's some other things going on, a lot of times we'll call the doctor and say, hey, this is what's going on. And they're like, man, I'd really like to see them in my office if they can get here. If the patient doesn't have a way of getting there, we can take them. And some of you may be thinking, safety, safety, safety. And there is something that I will address on that regarding our vehicle here in just a little bit. So look at the numbers. So I'm just singling out 2019 because that was really the first year that the Hope Center was fully in. So we had, the Hope Center had a total of 339 contacts. Of those, 64 were in the jail and 31 were in the school. I can tell you that through 2020, early 2020 numbers before COVID hit, that number was actually on par to be a lot higher. And now that school's back in session, we are starting to see those numbers tick up again, so we expect those school-based numbers to continue going up. The rest of them were others, and of those others, I didn't break these all down, but about 90% of those were 911 calls, and about 10% were calls that came in directly to the Hope Center. Total responses for the community paramedic in 2019 for mental health calls only was 120. What is so exciting about this is that of those 120, 85 of them were kept in the home and not taken to the hospital. When you look at a typical 911 response, that number going to the hospital would have been much different. I would think it probably would have been the opposite. 85 would have been transported of the 120, if not more of that. So throughout 2019, and we're seeing this trend continue in 2020. We don't have the numbers out yet, but 70% of the time, we have been able to keep that patient in the home and get them to the more appropriate care, service care, which we just think is absolutely huge. The 911 response from 2018 to 2019, as you can see, went up. And in the same time, although the mental health calls went down a little bit, the transports also went down significantly by, to 73%. But what we know is that a lot of times, because the Hope Center is there, a lot of times an ambulance wasn't being called. So even though a 911 call came in, an ambulance wasn't showing up. So the community paramedics and the crisis clinicians were going in first. So we also knew that there was another thing that we needed to work out, and it was Navigators. And I apologize for this slide. It didn't transfer over very well. But we have now hired 3 community behavioral health navigators. These individuals, I have 3 girls that work for me. They are non-clinical. However, they do come from social work, mental health backgrounds. And they're responsible for comprehensive management and care coordination throughout our county. So as you know, with a lot of mental health patients, there are so many other contributing factors that they need help with. A lot of times with funding of other things, their lack of food, barriers to care, all these types of things. That's where our mental health or behavioral health navigators come in, and they help them with insurance navigation, food support, charities, all sorts of things to give them the things that they need to be successful. We just started this I actually hired them the week before Eagle County and the state of Colorado shut down for COVID. So the first 4 months of their hiring, they were in here helping us with COVID. They were doing actually nothing with mental health because we couldn't get the program going off the ground when we were deep in the middle of COVID. So they've really just started hitting the streets and working with clients in the last few months. But we're very excited about what they do, and every time we talk to people who have dealt with them, they're just ecstatic. So we've got 3 full-time. They're Monday through Friday coverage, mostly daytime. They are available in the weekends as well, and they get referrals from the providers, from our community partners, and also from the community. And they are usually contacted within 24 hours, and they will meet with them and see what kind of services are lacking and try and help them navigate all those things. So I know that a lot of problems are, a lot of places around the country have the same thing, but these are kind of things that we talked about earlier. But when we talk about the lack of facilities, we also need crisis stabilization beds. We need short-term detox beds. We don't have a long-term detox program here in Eagle County. Many of the people that are interested in starting detox, if they are, they're going to have to travel a very long ways to get into this program if they can get in. And the waiting list for some of our programs here are very, very long. Another problem is if you're a parent who has a child or you are the only one in the home that works, a lot of times going into either a short or long-term detox program is not going to work for you, because if you go into a 30 or 60 or 90-day program, you're not going to have a job when you come back. Who's going to provide for your family? So we knew this was a big issue. We got a lot of people that are saying, I'm going to do it on my own, without meds or support or whatever. And most of the time they end up drinking again, or as you know, you're going to go into withdrawal, you're going to call 911, you're going to end up in the ED, you're going to end up in the hospital, something else is going to happen. And this rinse and repeat, we're just going to start this process all over again. So through one of our local care clinics, they have a PA who is the guru of substance abuse. It's what she loves to do. She works with these patients all the time. She is amazing at it. So her and I got together and we created the Community Paramedic Ambulatory Detox Program. We get referrals from all over for patients who want to enter this program, and so, what is ambulatory detox? So for that patient that wants to quit drinking but cannot go in, as Jonna likes to say, and she always said this to me and I say it to everybody now, if you quit doing drugs, most of the time you're going to feel like you're going to die, but you're not going to die. With alcohol, you can die if you detox wrong. We know that it's very dangerous to detox from alcohol if it's not done under medical supervision for the long-term hardcore alcoholics. So the patient is voluntary. The visits are voluntary. The patient, obviously, if the physician says, yep, here's the referral, we're going to give this to community paramedics, and they're going to call you, that we can call that patient. The patient says, nope, don't want your help. And that's it. But I'm sure most of you know that someone with an addiction problem is not going to quit until they're absolutely ready. And it may take 5 times going through treatment or even through our program or through a long-term care. It's a tough disease. So we see the patient 8 to 12 times, depending on their progress. We're going to see them twice a week for the first week, twice a week that second week, and then 1 to 2 visits the third and fourth week, kind of depending on how they're feeling. Medications. I did say this here. Detoxing from alcohol will actually kill you. That's from Jonna. The patient's sent home typically with a prescription. So patient goes into the ER or patient goes into their primary care physician, either currently intoxicated or just says, I want to quit drinking. And so the physician says, okay, we're going to send you home with 2 days worth of Ativan or Librium or whatever their drug of choice is. Typically it's Librium. And then we're going to refer the community paramedics out to you and they're going to come follow up. So then we will go out and we will do that. If a referral happened to come in from one of our field staff, so a 911 crew takes a patient or goes to see a patient, and for whatever reason the patient says something to them about wanting to quit drinking, our field staff can actually refer that patient to us, and through the medical director we create an internal referral. And then we work on a clinic because that patient's going to have to work with a clinic to get follow-up medications. So when we go in, everybody gets an H&P, vital signs, including a temperature and a blood glucose. Temperatures, I know, are not really popular in the MS world. People call them random number generators, but in the alcohol world, it's actually a quite important vital sign. A high temperature on a patient who is detoxing is a very dangerous sign, and so we're going to get that patient into the hospital more than likely. They're going to get a CWA, the Clinical Institute of Withdrawal Assessment, which is basically going to show you kind of where they're at on that detox scale, if they're kind of mild, moderate, or severe. We're going to give them a depression screen for the PHQ-9, social support evaluation, and then a lot of times we can actually, on those first visits, we can bring the Hope Center with us to help with some of those social evaluations and depression screens, things like that. They're going to get a primary care follow-up, and we're going to set them up with mental health. The other thing that we want to do is we want to try and encourage them to get some sort of alcohol support group or a community support group. And then our Hope Center is going to continue to work with them, because if you're under the assumption, and I don't mean this wrong, but if you're under the assumption that alcohol is just an alcohol problem and doesn't have a mental health component, you couldn't be farther from the truth. There is definitely a mental health aspect to this, and mental health is going to be extremely important as they move through that process. So has it been successful? So roughly 70% of the patients who refer to us agreed to be in this program. Of the last 15 that we enrolled, 11 are still maintaining their sobriety. And my favorite quote, and this was actually from last year, but I still put this in there. She said, and this was verbatim, I've struggled with this for over 20 years, and this is the first time I ever felt that I ever really felt like people cared about me. And I know that that's probably not true, that people had cared about her in the past, but when you end up in this system and you call 911 and you go to the ED, that's not a good thing for an alcoholic. There's a lot of judgment that goes along with that. There's a lot of eye rolling. We know nurses and doctors that just like, oh, so-and-so is here again. What do you want? What do you need? Why are you still doing this? And there's not a lot of compassion a lot of times. And I understand compassion fatigue as well, where you've given and given. But what they love about this is that someone comes into their home, and my community paramedics are very good. They will sit with them from anywhere to 10 minutes to 2 hours and talk, which is just the support that a lot of these patients need. So we're very proud of our detox program. So with that, I will leave you with a little picture of Marius, our little French bulldog. I hope you can see that well. And I am open for any questions or comments or anything, since we didn't really have anything during the presentation. So thank you.
All right, Kevin, thank you. There is a question in the chat box, and I'm going to unmute all the lines, and we'll see what questions people have. 1 second.
The conference has been unmuted.
I see from Leonard our slides available after the presentation. Since I don't have access to anybody, I can give you my email address, and I don't know if it's that on the front slide or not. I can double check. But I can give you access to my email. You can shoot me an email. And of course I didn't. I apologize for that. So I'm going to give everybody about 10 seconds here to grab a pen and a paper, and I will give you guys my email address. And if you email me, I can email you a copy of the slides. So I'll give it about 10 seconds here. And actually, you know what? I'm going to be even smarter than that. I'm going to put this in the chat box. So select recipients, broadcast all. So hopefully you should all see that. It is kcreek@ecparamedics.com. And if anybody wants me to shoot them a copy of this presentation, I would be more than willing to do that. And I should be able to get that out to you within the next few days.
Okay, any other questions for Kevin?
Hey, Kevin, this is Scott O'Connor from Greensboro, North Carolina. How are you?
I'm good, Scott. How are you?
Enjoyed the presentation today.
Thank you.
Did the county commissioners, or when you started the funding part for the mental health with the community paramedics, was this done through all the city, or was it through city and county, or for the state, or how was it completely funded?
So the ballot measure was for county. That was an Eagle County ballot measure that did not affect the rest of the state. And obviously the county commissioners were very involved in that. We did not break it down into city. This was a county-wide program. And that is what has helped fund all of the mental health initiatives that we have started through those tax dollars through the ballot on marijuana.
Okay, and the other question is did you do any additional education with the community paramedics, or was what they received in their initial training enough?
No, so we obviously, through community paramedic training courses, there wasn't a whole lot on this kind of stuff. We worked with a lot of our, number one, we worked with the Hope Center and their clinicians to come in and do some training. And then we also just worked with some of our local providers to come in and do additional training for our CPs to be able to work with these types of patients. And really, it was funny because, you know, the very first, I was still working as a CP. I'm now in management, but I was still working as a CP when this started. And I remember going out on the first crisis call and going, oh boy, here we go. You know, so it's definitely a learning experience. We lean a lot on the Hope Center for the mental health stuff, and they lean a lot on us for the medical stuff, and then we work very well together. You know, there's a lot of times where the patient is just, for whatever reason, doesn't have the best connection with that clinician, but they have a better connection with the CP. And so there's a lot of going back and forth during, you know, these calls can last anywhere from 30 minutes to 3 hours. And there's a lot of that. So,
okay. Is there any involuntary commitments from the CHP part, the community paramedic part?
So the Hope Center, they are able to place patients on an M1 hold, which is what we do for our patients here in Colorado. And that is obviously if the patient is a danger to themselves or others or things like that. And then they work with the emergency room, and typically that patient is going to end up in the ED, and then ED is going to call our 911 division, and that 911 division is going to take them to a more appropriate location because we don't have anything here in Eagle County as of this moment.
Okay, thanks. I appreciate it, and great job.
Thank you. I see something from Leonard Coleman. Do they give IV ketamine therapy for suicidal non-bipolar patient or depression at the Hope Clinic? No, they don't. All the medication that's going to be, other than the PO Ativan that I talked to you about for the patient who's just a little bit upset, there's no medical intervention that's done for these patients in the home. Now, that is always something we've looked at. Our ambulances give ketamine, but we haven't done it for the non-bipolar depression
Kevin, I think his question was whether they do it at the Hope Clinic, not at the house.
No, they don't. They do not at the Hope Center. They are working with a mental health nurse practitioner to be able to get in and do some other things like that. But those are things that are still in the works at this time.
Any other questions for Kevin?
Hypnotherapy. No, they do not do that either. I have not heard them talking about that. That's a very interesting question. I've done a little bit of research on that and have heard some good things about it, but I just don't know enough about it to be able to comment other than I know they're not doing it at the Hope Center.
Any other questions
maybe
for
it.
Kevin? All right. Well, Kevin, it's been cool to see your program grow over the years, and it's nice to connect up with you again. We will place the recording. We will place the recording for today's session on the CPIF.communityparamedic.org site. Then you click on archives, and you can see all of the sessions that we recorded back to 2011. And it should be available sometime tomorrow. So please look there, and Kevin will announce soon the next date and topic. Thanks, everybody, for joining us today.